But thanks again, Derek. There we go. Thank you again, Derek, for helping always. But today I'm excited that we do have a panel discussion on discharge planning related to current barriers, community resources, and overcoming challenges in the journey from home to a hospital or a skilled nursing facility, especially during the times of COVID. We have three professional panel experts with us. First is Maureen or Mo, who did get to say hello. Maureen is a LMSW who graduated from Shepherd University and has worked as a social worker in the healthcare industry for over 20 years. For the last 9 years, however, she has worked at Heritage Hall in downtown Leesburg, where she's currently the Director of Social Services. Thank you, Maureen, for joining us. Next, we have Melissa Suzuki. Melissa graduated from the University of South Florida with her BSW and MSW. She has been a medical social worker since 2012. Her primary focus has been the acute care hospital setting recently, but has also worked in the rehab skilled nursing in the past as well. Melissa currently works in case management for UVA Haymarket Hospital. And lastly, we have Crystal Corbin. Thank you, Crystal, for joining us. Crystal has her MSW and is currently a case manager, discharge planner at Encompass Rehabilitation Hospital of Northern Virginia over in Aldie. Crystal graduated with her MSW from Howard University and also has her doctorate in healthcare administration from the University of Phoenix. But otherwise, I will give it back to you, Derek. But thank you all for joining us and very excited to hear what you guys have to say to update us.
Thanks, Eric. We've got Maureen and Melissa spotlighted. Crystal, I'm spotlighting you, but actually, I don't know if I can unless your camera can work, but you can at least talk.
There we go.
Okay, cool. Excellent. All right.
Oh, well, I'll go ahead and start, I guess.
Yeah, that's great.
This is Mo, social services at Heritage Hall. My background, I've been at Heritage Hall for 9 years now, but I worked in assisted living for a few years, but prior to that, I was a hospital case manager, medical social worker for 15 years. So I think obviously, like I said before, I wanted to thank everybody out there for providing all the services to our disabled and to our seniors, especially during this time. I feel like because of COVID, obviously we deal with some very delicate situations. We do a lot of conflict resolution, discharge planning, end of life planning. We help families and patients, residents, they're thrown into a situation as kind of a baptism by fire, and we try to help guide them. I feel as if a lot of challenges with healthcare in general has made things even more difficult for our families and residents in the community. There is financial issues that, people have. I help with Medicaid and things like that. And it's not an easy process. And I feel like what's happening, obviously, for Michelle can attest to this, and even Crystal, the amount of time that people have in the hospital is shorter and shorter. Acute rehab, that length of stay is a very limited amount of time. So, discharge planning on all ends starts right from the beginning. And that happens here in our setting. As far as for skilled nursing, we almost have to act like probably years ago, the hospital setting where people stayed longer and were more prepared, versus you come in, you go out, here are your choices, pick one and move on. So I feel like with COVID, there's a sense, a lot of our seniors have been isolated. There's a lot of fear. And I just feel as if there's a psychological piece of things where people are more stressed out. The the amount of care that our seniors need is heightened, but then there's a lack of even caregivers out in the community, even within the facility. You know, you see CNAs, we need CNAs. There's such a need, and they don't get paid very much, and they are dealing with, you know, residents and families, and dealing with very, you know, personal care. It's a very difficult job. So as social workers and discharge planners, you know, we're supposed to have a safe discharge, put things in place, and, you know, we have our magic wands, and we're trying to make everybody happy, but it doesn't work that way. And I just feel like it's even more challenging now than ever. I don't know what everybody else thinks as far as on the panel, but equipment's difficult, getting care, expectations, and workload is all very much heightened, I feel, at this time.
And I can agree with you, Maureen. You know, at Encompass, we are acute rehab. So like you said, the length of stay is very short. We're looking at 7 to 10 days, sometimes 7, sometimes 5. With COVID, we do get a lot of managed care patients, and they have these COVID waivers. So the managed care companies are only authorizing 2 days. So as soon as the patients are getting in, therapy have to see the patients day 1, so we can assess length of stay to try to get that time. So challenging trying to get insurance companies to get on board. Equipment is definitely a challenge as far as inventory. There's, you know, I remember one time I had to do discharge planning with oxygen. No one had concentrators. So it's just, you're very limited. So, you know, and it's like calls like this is very helpful for me as a discharge planner, because I'm given like a week to discharge plan, get them out the door and do it safely. Especially, you know, and I appreciate a lot of the ALFs, a lot of the assisted livings that come to our rescue. I mean, I appreciate you guys. I mean, I've worked with Andrew, I've worked with Brady. I mean, you guys like are awesome. They'll come out, get your patients out in the day. So that helps us. So I do appreciate that. I need to get, you know, I'm from the Maryland area. You know, I've been working in Virginia for about 3 years because I came from Nova Alexandria as a case manager. So I'm building my network in Virginia. So I definitely, if anyone could email me your resources so I could give it to my team. It's 5 of us there and a director. So definitely, if you could email me your information, your resources, especially home modifications, ramps. We're getting a lot of that. Assisted livings, home care. I'm getting a lot of patients who need private duty, because a lot of older patients are electing these surgeries, which is, you know, they get knees and hips, and a lot of times their spouses cannot provide the care that they need, especially if they're non-weight bearing. So that I need private duties. We're seeing limited staffing in those areas with home health. Staffing is definitely a challenge, especially in Fauquier County. So if I have a good home health agency in Fauquier that has good staffing, please email me, me and my team. But other than that, again, I appreciate this call and being on the panel. So thank you for the opportunity.
And Crystal, you know, feel free. I mean, I'll even give you my cell. You know, I'm always a resource, and I like to bounce ideas and difficult situations. I mean, we take residents from Encompass as well. And you're right, managed care is a whole other situation. We get the same thing. We'll get them from the hospital immediately, 2 days. They want an update, and then they give a last day of coverage. So it is a challenge, and I appreciate it. And I appreciate it's tough out there, and we try in our hearts in it, right? We're all here for a reason, because we care for, you know, I care deeply, you know, for these residents and at this stage of life, you know, and we're, you know, it's we're in it together, sister.
Yes, thank you. And Heritage Hall always look, you know, the SNFs too, because, you know, ultimately from acute rehab, that is not our goal for any of our patients to go to a skilled nursing facility. We get dinged really bad for that, but a lot of times we do realize these patients cannot, they need additional therapy. So the skilled nursing facilities also help us out for discharge planning as well.
And also if they don't have, it's, you know, utilizing those resources if they don't have that financial piece of things to pay for that private duty at home. You know,
so they do use that SNF so they could use their Medicare benefits. So yes,
awesome.
And equipment is it's
good
tough.
information. I guess from like the acute, like the hospital setting, you know, we utilize both the SNF and the acute rehabs quite often. It has been a challenge since COVID happened with getting, you know, the SNF placements because of all of your regulations with isolating and bed availability and things like that. And then of course, we're all seeing staffing issues across the board, not just like, you know, from home care to the hospital to SNF to acute rehab. I mean, it's affecting all of us in regards to staffing. And so that can play a part as well when it comes to discharging patients from the hospital, trying to get them into a rehab facility. You know, just delaying the admission date because of lack of beds or lack of staffing, or they're not able to take any admissions because they're on like a COVID kind of quarantine period. So that is, you know, we're seeing longer length of stays here in the hospital because of it. Acute rehab, we work with you guys and Aldi, we work with you all the time. You know, we love Rachel, we love April, Jillian, all of them. They're great. They really help us out. And a lot of times, especially with some of our patients who come in and are uninsured and we need to get charity beds or things like that placed for them, you guys are basically the only rehab that we can get set up for them. A lot of the home health agencies sometimes will try to help us out with charity visits. But if we can try to get them into you guys, that's the number one, you know, plan that we try to go with. So, in regards to like other barriers related to COVID and discharge planning, I mean, realistically, it's the biggest ones that we're seeing are the staffing issues. The managed care, you know, insurances are becoming more and more prevalent. And so it's harder and harder to find home health agencies. I'm sure you guys are seeing this as well. It's harder and harder to find home health agencies that are willing to accept these patients because of the managed care and the reimbursement rates and things like that. And then of course, you know, like with the, just like the shortage of like being able to get like the COVID tests done for patients even, you know, we used to kind of do them on everybody whenever they were admitted to the hospital. We've since stopped that, and we only do them on patients who are actually exhibiting signs or symptoms of any sort of respiratory issues. And then, you know, in order to get them to a rehab facility, you know, I know the skilled nursing facilities, at least they require a rapid COVID test. And sometimes we don't do the rapids anymore. So it takes us 4 hours, if we forget to request it the day before, or if the, you know, the change or the plan changes the day of, you know, then we're extending that time frame an additional 4 hours, just trying to get that COVID test done to get the patient out. You know, luckily for acute rehab, you guys don't request the COVID test unless the patients were in a fever. So that helps a little bit, but it's been a challenge lately with COVID. I mean, it's just been really tough to get these patients, you know, and then not to mention the just how overrun the hospitals have been lately. You know, I mean, here at Haymarket, we've seen some of our highest census numbers since the hospital's been open just in the past, you know, year. And then Prince William, you know, they were running with constant boarders in the emergency room of like 20 plus patients just sitting down there waiting for beds because that's how full we were in the hospital. And then you got, you know, the discharge barriers to get patients out. And so you're not keeping that flow up with, you know, the ebb and flow of getting people in and out of the hospital in a timely fashion and things like that.
And it affects length of stay and everything.
So it affects everything. And then everybody's just under this constant pressure.
Pressure cooker. So why are they not out? What are you doing?
Right, exactly. So I mean, I'm sure you guys feel it too, you know, it's tough. It's so and you know, a lot of times it's not stuff that you really have any control over. You know, you're working with so many other factors that play into a discharge. It's not as simple as like, oh, okay, you're going to go to rehab. No, well, you know, you need to set up transportation, you need to make sure all this paperwork is done, you need to get the COVID test, you need to get this, you know, so there's a bunch of other things.
Orders, changes in orders at the last minute.
Right. Get the discharge summary, make sure you have the scripts, you got to call, you know, family and then the patient
or the family
on board. Yep. So it's a lot of stuff that comes into it. And you know, it's not as easy as people who aren't in this department think it may be. So yeah, so it's definitely a challenge. It's starting to kind of slow down, you know, as we've been seeing the COVID numbers decrease. A lot of that has been starting to slow down. We're starting to feel like we can breathe a little bit easier now, which is helpful. You know, just like in our department here between Prince William and Haymarket, we've been extremely short-staffed since December. And so between Vicky and I, who are primarily here at Haymarket, we've been floating over to Prince William to help out with cases and things like that, just because of the staffing issues. So so yeah, so it's been a real struggle, but hopefully, knock on wood, we're starting to see the light at the end of the tunnel. Things are starting to get a little bit better, a little bit calmer. You know, as the warmer weather comes up too, you know, you don't have to deal with a lot of the other respiratory, you know, things that come into play, like your flu season, your pneumonia, all of that stuff that kind of that already brings in a high number of patients. And yeah, so hopefully we'll start to see our numbers start to decrease and give us a little bit extra, you know, room to kind of really focus on our discharges and making sure that we're getting everything squared away. Because I don't know about you guys, but I have felt like for the past year and a half that I am not, you know, doing 100% of what I should be doing when it comes to my discharges. You know, I'm getting things done, but I'm not getting everything tied in a nice little bow that I normally would like to do. So,
and you know what? And I agree with you. First of all, I want to say, if I need a walker, I'm coming to you. No, I'm just
right.
kidding.
Yeah. Oh yeah. Cause I mean, that's what we have to do. So we've worked with we've had to work with our vendors to make sure that we keep walkers.
Oh yeah.
You know, in stock. We at least have like 10 to 15 walkers constantly. We have oxygen portable tanks that we keep in stock here. And then the concentrators have been an issue, you know, with trying to get concentrators. So sometimes we still can't discharge a patient because they can't get the conconcentrator set up. We can give them the portable tank to get home, but you know, once they get home and that runs out, they're
Good luck.
yeah, it's no good. So so we've been hit with that too. And the DME has been a real struggle. And hospital beds, I mean, forget it. You're waiting days for a hospital bed, you know, and if the patient really needs it before they can leave, then guess what? They're sitting here waiting, you know.
Are you guys using Parachute?
What is that?
Yes, we
Have you used
we
Parachute?
use
DME?
Parachute.
Do you should
Yeah,
try
we do.
that.
We
do,
use
Crystal?
Parachute. Yes. We use
Okay.
Parachute. It's so much easier.
It's much easier.
Yes, much easier, it's quicker, it's faster. I do know Encompass is adding on 15 new beds, so they're starting construction soon.
Woohoo!
Wow.
They also building another hospital in Bowie, Maryland. So I mean, they have good things going on. And like you said, Melissa, we do take charity patients. I have like 3 of them now. And you know, as a case manager, our goal is to try to get them to the community safe, even though they're charity. I do know with Inova, if the patients have come from their hospital, we have like an agreement, they will give them DME and provide home health. So it makes us easier to, you know, take the charity patients. But yeah, we're building more beds. So
That's awesome. And
I can't
charity patients is a huge help. I mean, it is a huge help from the hospital standpoint with you guys taking them, because, you know, a lot of times these patients, they may have the family support, but they just don't have the ability or the means to take care of the patient at that time, you know. And I mean, we all know, like our Fairfax, Manassas area, there's a high influx of, or high population of like undocumented, you know, citizens that are there. And it's really tough to find resources for these patients because they won't qualify for Medicaid, they won't qualify for, you know, all of these, you know, county programs. And so the fact that you guys can take them and actually work with them and give them that rehab is phenomenal. So yeah, you guys are usually the first ones I look at when I have a patient that's in that situation. So
and then usually the charity patients, they usually stay about 2 weeks. I haven't had a charity patient that stayed over, and we were pretty successful with getting them back to the community and getting them, you know, resources. If it was no more than like 1 or 2 visits, because our home health agency picks up a lot of that too. They'll give like 1 or 2 charity visits at home. So it helps.
Good.
Yeah.
And so we actually here within the UVA system, we have a contract with Adapt Health. They like are one of the larger, DME companies. They do oxygen, wheelchairs, walkers, everything. They own Roberts, Home Medical, that kind of stuff. So we typically have to go through them for our DME providers, but we're always open to trying other ones. You know, it's not like we don't have to absolutely use them. So if we're able to find other providers who can, you know, get things done in a more timely fashion, then we're always open to hearing that and seeing what we can work with.
Yeah. I think, overall with all the stress of everything too, I feel like we, just like you were saying, Michelle and Crystal, I know you feel it too, and everybody probably on the call, that education and support that you try to, do as a social worker, it just becomes very quick, right? Sitting down, spending all that time educating someone who doesn't realize that their managed care, doesn't provide any really good benefits.
Yep.
With that, what do you mean home health isn't going to move in with me?
Yeah.
What do you mean I have to pay for that? So it becomes, and they're stressed anyways. It's just difficult out there. I feel like sometimes, we got that dam with all the holes in it, and we're like, especially, Michelle, it brings me back to when I was a case manager. Good Lord, I'm so sorry. And Crystal, I can't imagine acute
Yeah.
rehab, getting somebody in acute and getting them out in a couple days,
Yeah.
the level that they
Yeah.
need. And the charity piece of things. Yeah. And I don't know, Medicaid's a whole other beast. I don't know how much obviously, Michelle, I'm sure, do you guys do the UAIs, or do you have some?
Oh, yes.
Yeah.
I know from an acute rehab, especially if they're transitioning to a SNF, or if they want to apply for the waiver.
Yeah.
Yes.
Well, and that's a whole nother thing too, because some of the rehab facilities won't take them unless we do the UAI.
Right.
And so even though we tell them this patient's not going to stay long-term care, they'll still require it before we can discharge them. And that's a whole nother beast, because Virginia's UAI is 12 pages long,
Oh, it's crazy. It's crazy.
I mean, it makes sense though, Melissa, because you never know what happens once they get to acute rehab, or you never know what happens once they get to a SNF, because things could change drastically. So and I have about 15 years in long-term care as a social worker, so I understand both ends. So I'm sitting in a position where I have empathy for both, for everyone, because I did case management in the hospital, I did it in the SNF, I did it in acute rehab, so I can understand. So
same here. I was doing the UAIs out in Annandale for Fairfax County for a while. I was with the adult and aging, case management, Department of Social Services. It was a struggle out there too, but and kind of like you guys, like I feel like we all have dipped our toes in each kind of aspect of medical social work. And I did home health, I did SNF, I did the county, and acute care hospital is kind of where my passion is at. So I'm happy to be back here in the hospital and doing this. But it's good to have that kind of roundabout view and seeing it from the other side, and understanding it's not as simple as me just sending a patient to a SNF and being like, okay, I did my part, then you got to struggle with it, on your end, and trying to figure out, okay, so what's going to be the next step after here, and so so it kind of, like, me and my partner Vicky, we're always very open and honest when it comes to our discharges, and making sure that you fully are aware of what you're getting in a patient, and kind of what to expect, and not just from the patient level, but also from like the family aspect, and how much support or lack of support they have, and that kind of stuff. So
well, the whole thing is, it's the continuum. We're helping people from that hospital end out to the community, and trying to give them as much support and resources, and trying to do a safe discharge as best as we can, and doing all those things, and the whole UAI thing. And I won't even get to that. That's like with Medicaid and the new regulations and what they it's like crystal ball. I've got like my little 8-ball and my magic wand by my desk, so and I appreciate the ALFs and the home care agencies, the private duty, but like you said, Michelle, the staffing issue is just a continuum, and the expectations from patients and families, it's just higher and higher.
It is, and then depending on the area that you live in, because especially Northern Virginia, it's a very affluent area. And so you got people who, expect a certain standard of care and things like
Oh, yeah.
that. And so it can be very difficult and challenging dealing with family members in that regard, and kind of trying to explain to them, well, this is what they can qualify for, and this is what you're going to have to pay for, and
Right.
you can't have it both ways. And then or you can step up and kind of provide this care yourself. So yeah.
And trying to like, even when I bring up hospice a lot, trying to figure out what's going to be the best. It's like, okay, here's what we have to play with.
Right.
We don't make the rules, but these are the resources. So we're here to help you navigate as best as we can.
Exactly. And I don't know if you guys have seen it, but even with hospice lately, we've been seeing staffing issues. And so they can't even, where it used to be, we would do a hospice consult, and then usually they get, equipment delivered same day, next day, and then we discharge home the next day. We're not even able to do that so much anymore, because they're saying, well, we can't actually admit them until 3, 4, 5 days later. And so a lot of times patients, stay here until we can either do that, or we try to find another hospice agency, or so it's kind of, it's difficult having to go back and forth between so many different companies and trying to figure out who can do this the quickest,
Right.
So you can try to get the patient out and open up that bed for another person. So
It's crazy out there, everybody. Hang in there. We're in it together.
Yep. If you guys know people who want to work in healthcare, I know not many people want to work in healthcare right now, but if you know anybody, definitely send them our way. I mean, we have open positions pretty much everywhere. And I'm sure that's the same for you, Crystal, and you, Mo, and all of the home care and assisted living facilities, and just everywhere. So bring them on board.
And again, if everyone, I put my email in the chat, if everyone on the call who have home care, DME, oxygen, even I heard someone was from a life insurance company. We get those questions all the time, believe it or not. If you can send me your information, I will pass it on to my team. Maria Kopek is our marketing director at Encompass in Northern Virginia. That's Maria Kopek. Our number I put it in the chat, my number, or you can email me. I can send you her information. But we're always looking for patients. We get them from all over. I got a patient from Delaware the other day. So, we get them all over. So just send them my way. And again, thanks for the opportunity. I have to head up to another meeting at 9:30. That's why I'm in my car. I'm driving. And then I'll be back in the office. But again, thank you for the opportunity. And email me your information, everyone, please.
Yeah, and I put my email on there as well. You can always, contact Heritage Hall. I'll put our phone number here. I like to network and bounce ideas off of people too. So, we're in it together, and I thank you the opportunity for talking today.
Thanks so much, Mo and Melissa and Crystal. Thanks for joining us. I'm going to ask Mo and Melissa if you just can stay on for a few more moments, just take a couple questions. I know Crystal has to bounce. Do you guys have a couple more minutes?
Sure.
Yeah. Okay. Excellent. So yeah, we'll just open it up here. And sorry about the little recording pause thing. I was trying to click on chat. I clicked on the recording button earlier. So yeah, if anyone wants to go ahead and turn your camera on, if you've got a question, I'll just go ahead and spotlight you here with the panelists. You can ask your question. I've got Andy's cameras on, Mamta's cameras on. So Mamta, do you have a question? I saw you first.
No, I came late. I'm sorry, but I just wanted to introduce myself. I'm an internal medicine physician.
If we'll come to you in just a moment. We're just looking for some questions for the speakers at the moment. But we'll come to you soon.
Okay.
It's all good.
Yeah.
All good.
Yeah.
Andy, let's go ahead and get you up here.
Yes, thank you all so much. Just had a quick question for you. So it kind of echoes everything that you all just talked about. I'm right next to, my office is right next to our director of nursing. And honestly, I have no idea how she does it every single day. I'd have panic attacks every day. So just it kind of leads me to a question kind of on the assisted living side. And I'm sure our home health care side as well. what would make the process, are there any best practices that we can use to make the process easier, on your end when it comes to discharge? Anything that, maybe we're not doing, anything that some people do that really make it helpful for you? Just kind of wanted to get an idea.
I can say with the assisted livings, especially, you guys at the Tribute, always easy to work with. I've been able to, I feel like we've been able to turn discharges, around pretty quickly. The assessment, even doing, like a video chat, trying to get paperwork completed. For us here, as far as from SNF, I feel like the process has been really good with you guys, and most of the assisted livings, I have not had an issue. From the hospital side, I don't know. Weekend discharges probably might be a challenge, getting paperwork. Michelle, I don't know, not speaking for you, but I would think that would be probably, new patients. I know sometimes they don't like to admit on the weekends, but.
Well, and to be honest, we don't work with we work with Heritage Village, which used to be part of the Tribute, but now I think they're kind of like their own separate thing. So we haven't worked with the Tribute. I'm guessing you're the one out in Woodbridge or?
One Loudon.
Well, oh, okay. Yeah. So no, we haven't worked with you guys yet, but just like in general, I think from the assisted living side, definitely having somebody come out to the hospital to assess the patient, give us the paperwork in a timely manner that we need to get completed by the doctor, things like that would always be helpful. And then of course, kind of helping to coordinate that whole admission process with the family and with us, and keeping us in the loop, and making sure that it's kind of like a seamless transition, and that they're getting like the families moving all the furniture and stuff like that in either the day before or the day of, before we discharge somebody, making sure that all of that's kind of taken care of to not like push anything back. The assessment, I think, and the assessment and the paperwork are probably the two biggest things. So just having somebody come out to do that themselves instead of relying on what we're telling them and having to send all this extra information and clinical documentation. It's definitely a time saver in that regard. And then yeah, if they can do admissions on the weekends, that would be awesome. Because hospital and it will, everybody is 24/7, and so we don't like to hold discharges on weekends just because of placement issues, but it happens.
It does.
And so and so if people are able to work with us and get people in even on the weekends, that's a huge help.
Yeah, I think it's as far as for discharge planners, it's having that other entity doing a lot of the footwork, a lot of the communication with the family, just like you said, getting paperwork. I don't know about you, but we fill out most of the paperwork and the physician sign it, because otherwise you'd be waiting like a year for paperwork to be completed. So, but I think in general, I mean, my relationship with the ALFs out here, I feel is, good. I think the communication's really good. And I think in general with everybody, communication's the key. Mm-hmm. Transparency is the key. If somebody's difficult or, just like Michelle, like you said, upfront and honest, not easy, what the barriers are going to be, and letting people know that. And,
Yeah. And then, and letting us know like right away, like if you have any concerns about taking a patient of ours and you don't feel like you're going to be able to take it, I'm not going to be hurt if you tell me no, like
exactly.
I want you to tell me, day of, as opposed to like 3 days later while I'm still under the, anticipating that they can come there.
Exactly.
So like, tell me right away if you're not going to be able to take a patient of ours. So that gives me time to look for other avenues instead of wasting 3 days of the patient sitting here in the hospital and anticipating that we can get them out to one place, and then all of a sudden that falls through.
Exactly. Yeah,
that's great. Thank you.
Mm-hmm.
Rebecca, it looks like you've got a question, so I'll add you up here.
Yes, hello everyone. Similar to what Andy was asking, but more related to home health and home care. I understand that some of the things are similar, the communication, I'm sure, if we can admit a patient, But is there anything specific that we could do to help out? Is there anything that you can think of that we could do differently or we could improve or?
More managed insurances. That's the biggest thing. I mean, we get so many, we have a lot of elective surgeries here at Haymarket Hospital, a lot of orthopedic surgeries that come in, and these patients are getting younger and younger. And so they don't have your Medicare, they have regular traditional commercial insurances. And especially for us, you know, they live out in outlier areas. So they're coming from Bealton, Culpeper, Front Royal, Winchester, all over. And it's difficult to find a home health agency that is willing to take somebody with a managed insurance that is out in, like, you know, a more rural area. So
yeah, I think
that's the biggest thing for us.
And I think it's difficult in general because the reimbursement's so poor. And then if you're sending somebody out, you know, outside, like the outliers in the other areas, and I don't, you know, if you've been on the receiving end as far as home care is limited. They come out once, twice, and then they're out the door. But I think as far as with home health, you know, communication's the key, getting in touch with the families right away, communicating to us, giving us feedback. If you can provide, like, I know with Care with Love, you know, private duty, if somebody contacts you, letting us know, you know, as far as can you staff, meeting with families ahead of time, giving them that comfort level, as far as private duty, the cost, and trying to match up the right person, you know, as much as you can, because usually when somebody needs 24-hour care or hourly care, it's pretty quick. And families, you know, there's a trust factor there, having somebody in their home, and it's, you know, so there's a lot of things that go into that. But I think, like, communication is the key, you know, as far as I can, transparency, letting us know, hey, can you do this? Or if you know that you can't, you know, like Michelle said, our feelings aren't hurt. We just want to, you know, make sure somebody has the services that they need. That's all.
Right. And you know about what you're saying, like coming in person to talk to families, we are doing that now. Unfortunately for COVID, we had to do all our intake assessments over the phone or Zoom, but now we're coming in person, and you're right. It gives a different credibility when we show up in person.
For sure.
So we are adjusting as COVID allows us to. Thank you so much.
We appreciate, you know, obviously we've had COVID and the SNFs, you know, we've been through 4 rounds of COVID, I think, here. You know, it's pretty devastating. It's devastating for families. We deal with that in itself is hard. So that's why, you know, SNFs get a little paranoid about taking people in and worrying about outbreaks and visitors coming in. But I feel like we are hopefully, you know, getting through this, coming on the other side, I hope.
Yes. Well, thank you so much for all you do.
You too.
Chris, I see your camera on, or do you have a question?
Yeah, sure. Thanks. Good morning, folks. Going on to that same topic, Maureen and Melissa, home care, you know, being in home care and going into these outlier areas, it's very difficult to find staff. It seems like sometimes that home care agencies are the employer of last resort for some folks, unfortunately, but we wish it wasn't that way. And sometimes, you know, in the industry, we're looking for someone to fill a job or fill a case, and they're not an employee yet. So if you were to call today and say, hey, they need to be discharged this afternoon, do we have somebody? Probably, maybe, but if we had 3 days, 5 days, who knows what else we could get. So I don't, do you have a suggestion for us? Because it is almost we get a client and then get the caregiver. It's kind of switched. It's kind of the other side of the pendulum, as opposed to having caregivers and then getting the client. So any suggestions? That would
So
help
basically what you're saying is, you, like, if I were to call you, Chris, to give you a client, you'd accept the client before you have a caregiver. Is that correct?
No, I would not. But I tell you, okay, I don't have a caregiver. I have to go find one.
Right.
But that's, I guess, the industry in itself, and more the big picture. where we're looking for the caregiver after we get the idea that we have a client.
Right.
It wasn't like that, a couple of years ago.
And I think that's one of the challenges everybody has,
Yeah.
especially with private duty, just like you said, hiring people, hiring the right person, we just kind of, sometimes it's a roll of the dice as far as getting, matching people up. You might get 1 out of 10 caregivers who actually match up with the family's expectations and and the patient. But nowadays, even to have 10 caregivers,
Yeah, that'd be great.
right? Having the staff is the challenge. And just like you said, and the expectations and I get it, I think that's where the struggle for everybody is. There's a certain expectation if somebody's paying for a service, but the reality is the staffing and getting just anybody, and if their heart's not in the job, are they going to last? No, so it's difficult.
Yeah, to give you an idea, one of our Always Best Care franchises did a 3-month study. They had approximately 900 applicants for a caregiver job. And in that 900 applicants, they ended up hiring 4 caregivers, 2 of which were fired after the first day.
Right.
So 900 to 2 caregivers in Loudoun County. I don't know where you'd find 900 caregivers in 3 months in Loudoun County. So
oh, exactly. And I mean, let's face it, it is not an easy job. It's not an easy job. And as far as the payment for seeing aides and aides is not high.
Absolutely. All right.
Yeah.
Well, thank you. If you could start over the presentation, that'd be great. Went a little fast for me.
Thanks, Chris. Appreciate it. We'll wrap up the Q&A time there. Melissa, Mo, thank you so much for being here with us today. I will make this recording available to the LSIN members through our Facebook page and hope to have you on a future presentation.
Thanks for having us. Bye. Bye, Michelle. Have a good one.
Bye.
Everybody else. And happy Social Work Month.
Yes, happy Social Work Month.
Bye.
Yeah, bye.
All right, Eric, we'll get you up here.
There we go. So thank you, Derek, as always, for helping keep everybody in line for the agenda. Thank you so much to everyone. I know they popped off, but just to say thank you to our presenters just for their very candid insight into case management during such a continuing challenging time. So definitely thank them for their valuable time with us today. I do want to recognize our board members just quickly for all the hard work that they do, including finding our speakers and helping to arrange our different events and things. So I would like to recognize Michelle Darwin, Amy Copa, Leslie Katz, who is currently out on maternity. So thank you, Erin Nesbitt, for filling in. Peggy Breda, Steve Moss, Susie Serene, Andy Riley, Heather Price, Betsy Sue Scott as our legal counsel, and my illustrious boss, Jessica Ford, who I know is on the call. But next, I would like to do actually a spotlight. Capital, we have not done one in quite a while. So if you are a level 2 a resource directory advertiser, you can do a spotlight as well. So please reach out to me if you would like to do one. I'll put my email in the chat here after I am done. But just wanting to highlight Capital Caring. We're very proud that this year is actually our 45th year of service in the community. We were founded in 1977 and are proud to still be providing services that have expanded to primary care at home and palliative care, in addition to our original hospice services, covering Northern Virginia, DC, and parts of Maryland. March, Mo beat me to it again, but March is National Social Work Month with National Social Work Day on the 15th. So I do want to thank our social workers that did serve on this panel, as well as all of the social workers out there in various healthcare fields, as well as my own Capital Caring social work team that helped to provide the excellent care every single day of the year to our patients. But for some new updates, I'm very excited to share a hospital inpatient update. As you may know, hospice care does focus on managing a lot of symptoms, including pain to bring comfort and relief to patients and families to spend quality time together. Well, about 95% of capital caring patients do receive care in home or community settings. Those with life-limiting illnesses sometimes require a more advanced level of care and support that only an inpatient unit or IPU can really provide. So Capital Caring, we're still very proud to be the only inpatient hospice care available in Loudoun County at our Adler Center in Aldie. And now we're very excited to be the only one in Washington, DC as well. Our new inpatient hospice center opened on February 8th at Johns Hopkins Sibley Memorial Hospital with a lot of funding provided by the Washington Home Foundation. The new IPU at Sibley assures that those local hospice patients and families can access more intensive care when they need it. And being closer to home and convenience there in DC to have a second location for IPU services. The 10-bed hospice unit has medical care and social work support provided by Capital Caring. And again, thank you to the Washington Home Foundation for a lot of that funding. Lastly, I do want to highlight, and we'll post a little bit more on social media actually about this later, but on February 14th, on Valentine's Day last month, Capital Caring began providing companion robotic dogs and cats to all terminally ill pediatric patients. So we're very excited for that. I got to see one at our headquarters office and they are quite exciting. But these robotic pets by the Ageless Innovations, the name is called Joy for All. So we're very excited for that. They're very real to touch, sight, sound, everything. I can tell you firsthand from seeing one. And they're going to every child so they don't have to worry about any allergy issues and things of that nature. And thank you to Washington Gas and TEGNA employees for providing the support for that. And Jessica and I will share a little bit more about that on the Facebook page a little later. But those were just some updates from Capital for our spotlight. If you need any other information, you can always reach out to myself, Jessica Ford, or our 24-hour care line if you do want to make a referral or just need more information. So thank you guys for listening to my little spiel about Capital Caring. And again, if you are a level 2 directory resource sponsor, you too could definitely do one, since people do like to highlight their businesses, and we have quite a variety of services as part of the LSIN family. So please, like I said, I'll shoot my email in the chat here in a minute, but please reach out to me if you would like to do one. But otherwise, skipping to more important things, happy hour. So we're going to, we've decided to skip the March happy hour because it does fall the week of St. Patrick's Day. And I know that we have many other community partners that have events and things going on. So to not take away anyone's thunder and not to compete with a very fun holiday, we're going to postpone the one for March, but we will do one for April, which would be on the 20th of next month. And we do also look for a sponsor to help with that. Even 2 sponsors could co-share it if they would like. So that is something else you could reach out directly to either myself or Jessica as well if you have both of our info. Just to give some interest, you also have to be that level 2 sponsor for advertising to do that, but we would love to have someone volunteer to help us out for April. But otherwise, for announcements, Derek, I think I'm going to start passing it back to you for any other people that have any announcements, events, or any people that we might have missed for intros if you hopped on a little later this morning. But otherwise, our next, the networking meeting will be on April 6th, again at 8:30 with our presenter going on at 9. But with that, I will give it back to Derek so he can help to get anybody up and highlight any announcements, events, or any new people we missed. But thank you all for joining us today.
Thanks, Eric.
Yeah, thank you.
Let's go ahead and we'll pause the recording here.